The chief physician laughed at her scars in front of the entire emergency department. 32 staff members, patients in open bays, a janitor frozen mid-mop, and not one person told him to stop. The scars ran from the base of Claire Merritt's neck down to her left forearm, jagged and silvered and permanent. The kind of damage that doesn't come from a kitchen accident or a car crash. It comes from burning fuel and shrapnel and the decision to drag 3 men out of a vehicle that was already on fire. He didn't know that. He didn't ask. He just laughed, and the room laughed with him, and Claire Merritt stood perfectly still and let them, because she had survived things that would have killed every single one of them, and their laughter was nothing. Before this story goes any further, if you've never been to this channel before, hit that subscribe button right now, because we put out stories like this every week, and you do not want to miss what's coming. Tap the like button if Claire's already got you, and drop a comment telling me what city and country you're watching from. I want to see exactly how far this story travels. Now, let's go back to Harlow County General and to the woman they made the mistake of underestimating. The morning had started the way most mornings started at Harlow County General Hospital in Delmont, Wyoming, understaffed, overcapacity, and running on bad coffee and institutional momentum. The emergency department had been at 114% occupancy since the previous Thursday. There were patients in hallway beds. There were family members sleeping in chairs. There was a teenager with a broken wrist who had been waiting 6 hours because 3 separate trauma cases had pushed him to the bottom of the list. And every time a nurse walked past him, he looked up with an expression that mixed hope and resignation in equal parts. Claire Merritt had triaged that kid herself at 5:47 in the morning. She had noted his pain level, checked his circulation, told him she was sorry about the wait and meant it, and moved on because she had to. She had been on shift since 11 the previous night. Her feet hurt. Her left shoulder, the one that had taken a fragment in Kandahar, ached the way it always did in cold weather. And Delmont in late October was cold the way only high-altitude Wyoming could be cold, the kind that got into the walls of the building and stayed there regardless of what the heating system attempted. She was charting at the nurses' station when Dr. Harlan Voss walked in. Voss was the chief of emergency medicine at Harlow County General, a position he had held for 11 years and treated as a permanent condition of the universe rather than an appointment subject to review. He was 53, broad-shouldered in a way that had gone soft, and he had the particular confidence of a man who had spent a decade being the most credentialed person in every room he entered. He wore his white coat like other men wore authority. He was not a bad doctor. Claire had watched him work, and he was technically proficient, thorough under pressure, good with families in crisis. But he was the kind of man who had mistaken competence for superiority, and that was a different thing entirely. He noticed her collar first. Claire was wearing her standard scrubs, and the neckline sat where it always sat, and the morning had been hectic enough that she hadn't thought about it. The scarring on her neck was visible, not dramatically, not the full geography of it, just the uppermost edge where the tissue damage had climbed past her clavicle toward her jaw on the left side. She had long since stopped registering it as something other people would react to. That had been a necessary adaptation. Voss stopped walking. He turned toward her with an expression that started as mild distaste and escalated into something more performative as he registered the audience. 2 residents, a charge nurse, an orderly, a medical student on his 2nd week of clinical rotation. "Merritt," he said. She looked up from the chart. "Dr. Voss." "What is that?" He gestured toward her neck with his pen, not pointing at a chart or a patient or anything clinical, just at her, at her skin. "I've had 2 patient complaints this week about being distressed by the appearance of nursing staff. Administration is going to hear about this." The room had gone quiet the way rooms go quiet, when something uncomfortable is about to happen, and no one wants to be the person who stops it. Claire kept her voice level. "Distressed by what, specifically?" "Don't make me spell it out." He glanced around to confirm his audience, and something in his expression settled into satisfaction when he found it attentive. "The scarring. It's unsettling. We have a professional standard of appearance in this department, and visible disfigurement, she repeated, affects patient confidence in their care team. I'd suggest covering it. Turtleneck, bandage, I don't care. Just handle it before your next shift." The medical student looked at the floor. One of the residents had developed a sudden urgent interest in a supply cart. The charge nurse, Bev Okafor, who had been at Harlow County General for 19 years and had seen most things, stared at Voss with an expression of flat disapproval that she didn't bother to conceal, but she didn't speak either, because Voss was the chief, and she had a mortgage and 2 kids in middle school. Claire set down her pen. She looked at Voss directly, the way she had learned to look at things she needed to assess accurately rather than emotionally. "I'll keep that in mind," she said. "See that you do." He walked past her toward the physician workroom, coat trailing, already moving on to whatever came next on his morning's agenda. The room exhaled. The resident went back to his chart. The orderly pushed his cart around the corner. The medical student, a young woman named Priya, who would come to Claire 6 weeks later with questions about trauma care that her attendings hadn't answered, looked at Claire with an expression that was equal parts apology and something harder to name. Claire looked back at her chart. She finished the note she had been writing. She flagged a medication interaction she had caught in a patient in Bay 7, a 71-year-old man with atrial fibrillation whose previous facility had him on a drug combination that Harlow County General's pharmacy system had somehow not flagged. She walked to Bay 7, explained the interaction to the patient in terms he could understand, confirmed his understanding, and documented the conversation. Then she went to the break room, poured coffee she didn't particularly want, and stood at the window for 4 minutes looking at the parking lot while she did the thing she had learned to do in the Army when the situation was what it was and feeling something about it wasn't going to change it. She let it sit there without doing anything with it, and then she put it somewhere interior and functional, and then she went back to work. She had been at Harlow County General for 14 months. She had come to Delmont because her sister lived 40 minutes north of town, because the position had been open, and because after everything that had preceded it, she had wanted, not quiet exactly, but smaller, a smaller scale, a place where the stakes were individual rather than aggregate, where she was keeping one person's heart beating rather than making decisions that affected dozens of people simultaneously in conditions that defied description. She had not told anyone at the hospital about her service record beyond what appeared on her licensure documentation, that she had been a U.S. Army combat medic, that she had served multiple overseas deployments, that she had received her RN through the Army's bridge program and subsequently completed her BSN. She had not volunteered details. People asked, occasionally, and she gave answers that were accurate and minimal, and most people accepted that because she delivered it in a tone that made follow-up questions feel like an imposition. What her personnel file did not capture, because it was classified in the relevant sections, was the specific nature of her deployments, what she had actually done in those years, the particular circumstances under which she had received the burns that now marked her neck and arm, a convoy ambush in a mountain pass, a vehicle fire, 3 soldiers who were alive because she had gone back into the burning wreckage twice before the fuel tank compromised, what she had seen during those deployments beyond the purely medical, the things she had memorized, because in her experience the things you memorize precisely were the things that sometimes, later, mattered enormously. Harlan Voss did not know any of this. The hospital administration did not know any of this. They saw a 34-year-old nurse with visible scarring and a quiet manner who showed up on time and did her job without drama, and occasionally made clinical observations that turned out to be correct in ways that were slightly irritating to the physicians who had dismissed them. That last part had been accumulating. 3 weeks earlier, she had flagged a sepsis presentation in a 46-year-old woman who had been admitted for what the admitting physician called a urinary tract infection with fever. Claire had noted the heart rate, the respiratory pattern, the subtle change in the woman's mental status that the physician had attributed to her baseline anxiety disorder. She had documented her concern. The physician, a hospitalist named Dr. Ren Paulson, who had graduated 3 years ahead of Voss and shared his general philosophy regarding nursing staff, had told her to administer the ordered medications and trust the medical team to manage the diagnosis. The woman had decompensated 4 hours later. By the time the rapid response team got there, she was in septic shock. She survived after 3 days in the ICU, but it had been close, and the case had gone to quality review. And in the quality review meeting, Paulson had described Claire's initial concern as nursing staff overstepping their scope, without mentioning that she had been right. Bev had told her about that meeting. Bev told Claire most things, in the quiet way of someone who had decided that honesty was a form of protection. "He actually said that," Claire had said. "Word for word," Bev confirmed. And Voss backed him up, said the nursing staff needed clear guidance on when to escalate. Claire had thought about that for a moment. "The patient's alive." "She is." "Then I'm fine with how it went." Bev had looked at her with an expression that suggested she found this response both admirable and deeply exasperating. You know that's not normal, right? Most people would be furious. Most people haven't had the practice, Claire said, and didn't elaborate. The morning of the Voss incident, the caller comment, the audience, the performance of it, was a Tuesday. The shift continued without drama for the next 4 hours. She managed a chest pain presentation that turned out to be costochondritis, a laceration repair on a construction worker who stoically refused adequate anesthesia and then turned white the moment the suture kit appeared, a pediatric asthma case, 2 flu presentations, and a confused elderly man who had been brought in by his neighbor and who turned out to have a UTI that was making him seem significantly more cognitively impaired than he actually was. She explained this to the neighbor, who was relieved and grateful, and squeezed Claire's hand when she left. It was around 2 in the afternoon when the paramedics brought in the woman from the highway. The call had come in as a motor vehicle accident, single vehicle, rural highway, 12 miles east of Delmont. The paramedics had the woman on a backboard, cervical collar in place, 2 large-bore IVs running. She was conscious but confused, mid-40s, and her name, according to the ID in her wallet, was Sandra Pruitt. The mechanism was straightforward. Vehicle had left the road, rolled twice, driver was the sole occupant. Claire was the first RN at the bay when they rolled her in. She ran the primary survey the way she always did: airway, breathing, circulation, disability, exposure, and everything tracked with the mechanism of injury: laceration to the scalp, probable rib fractures, abdominal tenderness that warranted imaging. Dr. Paulson appeared at the bay entrance and began directing the workup, and Claire executed his orders without comment. But something was off. She couldn't immediately name it. It was the kind of clinical signal that comes from enough years of seeing enough patients, a pattern that doesn't quite fit, a detail that sits slightly sideways relative to the explanation. Sandra Pruitt's confusion was appropriate given the head injury, but there was something in the quality of it. The way her eyes moved, the particular character of her agitation, which was not the ordinary post-trauma agitation of someone who had been in a car accident and was in pain and frightened and disoriented. Claire had seen that agitation before, not in emergency medicine, somewhere else. She was hanging the 2nd liter of saline when she caught a detail on the woman's left forearm that Paulson had missed because he had been looking at the chest. A circular mark, older than today, not from the accident, not from the IV. A deliberate mark. The kind of mark that got made in specific circumstances that had nothing to do with car accidents on rural Wyoming highways. She noted it without expression and continued working. 20 minutes into the resuscitation, the CT results came back. The imaging confirmed the rib fractures, identified a small splenic laceration that was being managed conservatively, and showed no significant intracranial pathology. Paulson reviewed the imaging, declared the patient stable for floor admission, and began dictating his note. Claire did one more set of vitals. Blood pressure was 94/60. Dr. Paulson. She kept her voice even, clinically neutral, the tone she had learned to use when she needed a physician to hear information without getting defensive about who was delivering it. Her pressures dropped since the last set, 94/60. She's adequately resuscitated, Paulson said without looking up from his dictation. The CT showed a grade 2 splenic lac. That's managed conservatively. Her heart rate is 104 and her skin is mottled below the knees. Merit. He set down the dictation equipment. I've reviewed the imaging. The patient is stable. If you have ongoing concerns, document them in the chart and I'll review at my next assessment. When is your next assessment? He looked at her. The look had layers in it. Irritation, the reflexive authority of someone who was not accustomed to being questioned by nursing staff, and beneath that a trace of something that might have been uncertainty if he'd let it get that far. 2 hours, he said. Her pressure was 112 when she came in. It's dropped 20 points in 40 minutes. That's within normal variation for a trauma resuscitation. It's a trend, Claire said, in a patient with a splenic lac. I'm aware of what a splenic lac is. She held his gaze for 1 beat, 2. Then she said, noted, turned back to the patient, and pulled out her phone to document the exchange with a timestamp, because Bev had taught her that documentation was the thing that outlasted the conversation. Paulson left the bay. Claire stayed. She watched Sandra Pruitt's breathing. She watched the monitors. She watched the quality of the woman's consciousness, which was not improving the way it should have been now that the resuscitation was an hour in. She checked the abdomen again, gently, carefully, and noted the woman's face when she pressed on the left upper quadrant. Sandra Pruitt flinched. Her blood pressure alarm went off. 78/50. Claire hit the rapid response button, called out to the tech at the station, and began running the second liter of saline wide open before anyone else reached the bay. When the rapid response team arrived 90 seconds later, Voss first, because he happened to be on the floor, then Paulson behind him, then the surgery resident who had been paged. Claire had already pulled the ultrasound machine to the bedside and had the probe on the patient's abdomen. "Free fluid," she said, turning the screen toward Voss. "More than the CT showed. She's bleeding." Voss looked at the screen. He looked at the patient. He looked at Claire. "How long has she been like this?" "Her pressure started dropping 40 minutes ago. I notified Dr. Paulson." She kept her voice factual, not accusatory, because this was not the moment for that, and Sandra Pruitt needed the next 60 seconds to go correctly. Surgery took over. The OR was called. Within 8 minutes, Sandra Pruitt was moving toward the elevator with the surgery team, and within 2 hours she was out of the OR with a repaired splenic laceration that the surgeon later told Bev had been 20 minutes from becoming unsurvivable. Paulson did not speak to Claire for the rest of the shift. Voss stopped by the nurse's station at 6 o'clock, at the end of her shift, and Claire was charting her final notes and not expecting anything when he appeared at the edge of her peripheral vision and stood there for a moment. She looked up. He was not apologetic. She hadn't expected that. But there was a calculation behind his eyes that she hadn't seen there before, something that was trying to reconcile his morning performance with what had just happened and not quite managing to resolve the two into a coherent picture. "Good catch," he said. "Thank you." Paulson should have listened. She said nothing to that. It didn't require a response. "We'll review the case at quality," he continued, "for protocol compliance." "That seems appropriate," she said. He left. She finished her charting. She clocked out at 6:18 and went to the locker room and changed out of her scrubs and stood in front of the narrow mirror bolted to the locker room wall for a moment before she pulled on her jacket. The scarring was visible in the mirror, neck, left side, descending to her forearm where it disappeared under her sleeve. She looked at it the way she always did, as information, as history, as the record of a specific series of choices made in specific circumstances, the outcomes of which had been 3 soldiers who went home. She zipped her jacket and walked out to her car. The parking lot was cold, the sky above Delmont dark at 6 in the evening, the mountains to the west invisible now behind clouds that had been building all afternoon. She sat in her car for a moment without starting it. Her left shoulder ached. She was tired in the way she was always tired after a long shift, a specific fatigue that was part physical and part something less nameable. Her phone buzzed. She looked at it. Unknown number, but the area code was one she recognized. Federal, Washington adjacent, the kind of number that didn't call nurses in Delmont, Wyoming. She stared at it through 2 rings. Then she answered. The voice on the other end was a woman's, professional and clipped, and what she said in the first 15 seconds made Claire's hand tighten on the phone until her knuckles ached. "Staff Sergeant Merritt, I'm calling because we have a situation. We believe you may have been identified by individuals connected to the Serova network. We need to know your current location, and we need to know now, because in the last 4 hours, 2 people connected to an active federal protective operation have been killed. And we have reason to believe the next target is someone who can directly identify network members from the 2019 Carmel Pass incident." The parking lot was quiet. Snow was starting to fall, light and preliminary, the first of the season. "I'm in Delmont," Claire said. Her voice was steady. "Harlow County General Hospital parking lot." A pause. Then, "Don't go home tonight." The line went dead. Claire sat in the dark for 4 seconds. 5. The snow fell on the windshield and began to accumulate, and the lights of the hospital behind her threw long shadows across the asphalt, and somewhere in the east, beyond the highway, beyond the flat dark expanse of high plains that stretched toward the horizon, something that had been dormant for 5 years had just started moving toward her. She started the car. She drove 3 blocks before she pulled over again. Not because she was scared. Fear was a thing she had learned to locate precisely in her body and then work around, the way you work around a bad knee or a blind spot in your vision. She pulled over because the call had given her information, and information required processing before action, and driving while processing was how you made mistakes. She sat under a gas station canopy with the engine running and the heater pushing warm air at her face, and she thought about what the woman had said. Serova Network. That name had not existed in her vocabulary 5 years ago. She had known the operation by a different designator, a string of letters and numbers that meant nothing outside a classified briefing room. But she understood what it referenced. She understood immediately and completely, the way you understand something that has been living in the back of your mind for years, waiting to become relevant again. Carmel Pass, 2019. A convoy of 3 vehicles moving through a mountain corridor in conditions that should have been safe, through a route that had been cleared and assessed and signed off through channels that turned out to be compromised. The ambush had lasted 11 minutes. She knew this because she had counted, in the way she had learned to count time under pressure, not by watching a clock, but by the rhythm of her own actions, each one discrete and documented in her memory with the precision of a woman who understood that the after-action report began the moment the action started. 7 soldiers in those vehicles. 4 had made it out unassisted. 2 had needed help. 1 had been in the lead vehicle when it went over. She had gone back twice. The second time, the fuel tank had let go, and she had gone face first into the gravel trying to get clear of the fireball, and the burning fuel had caught her left side before she rolled clear, and when she came back to herself, the man she'd been pulling was already out, already 10 feet from the vehicle, which meant she had gotten him out before the tank went. She had no memory of the last few seconds of that, none at all, which her therapist at the VA had later told her was normal, and which she had accepted as information without finding it particularly comforting either way. She had also seen faces. The ambush had not been conducted by the parties the initial assessment attributed it to. She had known this the moment she saw them, not soldiers, not the militia group the intelligence had named, but contractors. Western trained by their movement and their equipment, operating in that corridor for reasons that had nothing to do with the regional conflict they were nominally attached to. She had reported this. She had been interviewed twice by military intelligence, had given descriptions, had been told the matter was under investigation, and had then been quietly rotated to a different deployment and had not heard another word about it. She had not forgotten the faces. That was the thing about faces seen under extreme conditions. They stayed. She pulled out of the gas station and drove to a motel 6 blocks from the hospital. Not the closest one, not the most obvious one she had registered in her memory months ago. The way she registered exits and alternatives in any environment she spent time in. A habit so old she no longer noticed doing it. She paid cash for one night. The clerk, a bored teenager with headphones around his neck, didn't look at her face or her scars. She went to the room, locked the door, pushed the desk chair under the handle out of habit, and sat on the end of the bed. She called her sister. "Hey," Nora said, picking up on the second ring. "You coming for dinner Saturday? I told the kids." "Don't wait for me Saturday," Claire said. "Maybe the week after. I've got something going on with work." A pause. Nora knew her sister well enough to hear the thing underneath the sentence. They had grown up in the same house, had learned together how to read the space between what was said and what was meant, and even 14 months of separate lives hadn't erased that. "Are you okay?" "I'm fine. I just wanted to let you know about Saturday. Claire." "I'll call you in a couple of days," she said. "Lock your doors tonight, both deadbolts." She hung up before Nora could ask the follow-up question she was already forming. She sat with the phone in her hand for a moment, then set it on the nightstand and looked at the water-stained ceiling of a motel room in Delmont, Wyoming, and tried to think about what she actually knew versus what she was inferring. What she knew. The call was real. The Serova network was real. Someone had identified her as a witness capable of recognizing network members from Carmel Pass. What she was inferring, that the identification had been recent, which meant she had recently come into contact with something or someone that had triggered it. She had not changed her routine. She had not made contact with any former military personnel, had not traveled, had not done anything that should have broken her civilian cover. She had gone to work, gone home, driven to Nora's on weekends, bought groceries at the same store every Thursday. She turned that over for a while. Then she thought about Sandra Pruitt, the mark on the woman's forearm, the quality of her confusion, the car accident on a rural highway 12 miles east of town, alone, no witnesses, and the way the paramedics had reported the scene, The vehicle already cold when they arrived, the woman having apparently been there for some time before anyone called it in. She reached for her phone and opened the hospital's patient portal on her personal device, logged in with her credentials, and pulled Sandra Pruitt's intake record. The emergency contact number was a Washington area code. She stared at that for a long time. Then she closed the portal, because whatever Sandra Pruitt was or wasn't, it wasn't Claire's to pursue through a hospital database at 9 o'clock at night in a locked motel room. She needed more than she had. She needed the woman who had called her to call back, or she needed to find another way to understand the shape of what was happening. She lay down on top of the covers with her jacket on and her boots still laced and set an alarm for every 90 minutes, because she was tired enough that she would sleep if she let herself, but not so tired that she intended to sleep deeply, and closed her eyes. She dreamed briefly and badly about the mountain pass, not the way it had actually happened, which was the version she could manage in daylight, the sequential, factual version, each step logical, each decision defensible. The dream version was the other one, where she was running back toward the vehicle and the distance kept expanding, and the man inside kept calling her name, and her feet moved, but the ground moved faster in the opposite direction. She woke herself out of it at the first alarm, lay still for a moment, then got up and washed her face in the motel bathroom sink. In the mirror above the sink, the scarring on her neck caught the fluorescent light. She looked at it for 2 seconds, then turned the light off and went back to the bed and sat with her phone and waited. The call came at 4:16 in the morning. Same number. Same woman's voice, but less clipped now. Not emotional, but less insulated, the way voices get when the hours have been long and the information has been bad. Merritt, I need to know if you recall a man, approximately 50, Eastern European, scar on the left temple, missing the tip of his right index finger. Claire's jaw tightened. She knew exactly who that description belonged to. She had described him herself to military intelligence in 2019, had drawn a composite image with a sketch artist, had been told the composite was useful, and then heard nothing further. I know who that is, she said. A pause. Then, he was photographed in Delmont 6 days ago, outside your hospital. We believe the Pruitt vehicle incident was a staged crash designed to insert her into your facility for proximity assessment, to determine whether you could identify network members. We believe the assessment came back positive. The motel room was very quiet. The heater ticked. Who's Pruitt? Claire asked. She's ours. She didn't know about you. Her operation was separate. The network used her position to run a parallel action. She's secure now. But the proximity assessment means you've moved to an active target category. Another pause. We're sending a team. We need you to stay off your routine. Don't go to the hospital. I'm scheduled for a shift in 5 hours. I understand that. Don't go. The line went quiet for a moment, and Claire heard something in the background that she recognized. The particular acoustic texture of a large operations center, multiple voices, equipment, the white noise of a room running at capacity. There's something else, the woman said. The witness we've been protective detailing for the past 8 months, he's here, in Delmont. We moved him last week as a contingency, and we're now assessing whether that move was also identified. She stopped. His testimony is the primary case. If the network silences him before he testifies, 5 years of federal investigation goes with it. And you're telling me this because they may try to use the hospital, the woman said. It's the logical access point. Controlled space, multiple entry points, civilian cover, proximity to both targets. We need someone on the inside who knows how to read it if it goes wrong. Claire thought about Voss's white coat and the way the room had laughed that morning. She thought about the motel ceiling and the dream and the snow on her windshield in the parking lot. Send me what you have, she said, and I'll need a name to call if the team is delayed. Calloway, the woman said. Special Agent Dana Calloway, Federal Task Force Sorova. My number is the one you have. Use it. She hung up. Claire sat with the phone in her hand until the screen went dark, and then she got up and splashed more water on her face and started thinking about the layout of Harlow County General. Every entrance, every service corridor, every camera position, every staff checkpoint, with the methodical precision of someone who had memorized buildings under worse circumstances than these and had needed that information when it mattered most. She was at the hospital by 6 a.m. Not through the main entrance, through the loading dock in the back, where the supply deliveries came in before dawn, and the security presence was a single camera mounted above the door and a keypad that all nursing staff had the code for. She badged in, moved through the supply corridor, and came up through the stairwell that opened near the back of the emergency department, the one that the overnight staff used when they wanted to avoid the main nurses' station. She had used it before during overnight shifts when she needed to move quickly between floors without going through the main corridor. The overnight charge nurse was a man named Harold Fitch, who was 61 and 3 years from retirement and had long since made his peace with doing exactly what was required of him and nothing beyond it. He looked up when Claire appeared at the station, registered her presence without surprise. Nurses came in early, it wasn't unusual, and went back to his documentation. She checked the census board. Occupancy was down from the previous day's crisis levels. The ICU had 4 open beds. There were 6 patients in the ED, none critical. She looked at the board for the internal medicine floor and found what she was looking for in room 418. The name on the chart was Raymond Dole, admitted 2 days prior for what the record listed as hypertensive crisis, managed medically, stable, but requiring monitoring. She did not go to 418. She simply noted the room, noted the floor, and noted which staff members were assigned to the team covering that wing. Then she went to the supply room and found what she needed. Not anything unusual, just the particular arrangement of items she wanted available to her in specific locations. Extra trauma supplies moved from central storage to Bay 2, a portable monitor positioned near the service corridor entrance. Small things that would mean nothing to anyone watching and would mean a great deal to her if the next several hours went the way she suspected they might. She had been on the floor for 40 minutes when Bev arrived for the day shift, unwrapping a scarf at the locker room door and carrying a coffee that was already half finished. "You're early," Bev said. "Couldn't sleep." Bev looked at her with the specific attention of a woman who had raised 4 children and spent 19 years in emergency nursing and could identify a person operating under sustained stress the way a sommelier identifies a wine, immediately, accurately, and without needing to make a production of it. "What's going on?" Bev said. Not loudly, not in a way that anyone 3 feet away could have heard. Claire thought about the answer for a half second. She didn't have clearance to share classified information with a civilian. She also trusted Bev Okafor more than she trusted most people with clearances. "If something unusual happens today," she said, matching Bev's volume, "I need you to follow my lead without asking me to justify it in the moment. I'll explain everything after. Can you do that?" Bev studied her face. "You in trouble?" "Not exactly." "Is someone else in trouble?" "Possibly, yes." Bev took a long sip of her coffee, set the cup on top of her locker, turned to look at Claire directly. "Last time somebody asked me that, I was 26 years old and working a night shift in a Detroit trauma center, and a cop came and shot. Worst 6 hours of my life." "This might be in that category," Claire said honestly. "Fine," Bev said. "I'm following your lead." She picked up her coffee. "But I want a complete explanation, every detail, after." "Deal." The morning shift began without incident. Voss arrived at 7:30 and did not look at Claire's neck or speak to her directly, which she registered and moved past. Paulson arrived at 8, also did not address their interaction of the previous day, which was standard. He would process it internally, decide he had been justified, and that would be the end of it as far as he was concerned. She had seen that cycle before, and it had long since stopped requiring anything from her. The ED received 6 new patients in the first 2 hours of the day shift. One was a diabetic with a foot infection that needed admission. One was a child with a fever that turned out to be a simple viral illness. 2 were the routine texture of a Tuesday morning in a mid-size regional emergency department. Injuries and ailments that were real, but not dangerous. People who needed care and got it. The 5th patient was a man in his late 40s who presented with chest pain, diaphoretic, mildly confused, assisted in by 2 companions who identified themselves as friends. Claire was triaging the waiting room when they came through the door, and she clocked them immediately. Not the patient, but the companions. The way they moved. The particular configuration of their attention, which was oriented not toward their allegedly distressed friend, but outward, toward the room, mapping it. She finished the triage assessment she was doing, handed off the form to the front desk, and walked toward the chest pain trio at a pace that was professional and unhurried. "Can I get a wheelchair for him?" she said, directing the question at the companions while watching their faces. "He can walk," said the taller of the 2. in English that was fluent and nearly without accent. "Hospital policy for chest pain presentations," she said. "It's about liability. Let me get the chair." She went to get the chair. On the way, she took a route that passed the supply corridor entrance, and she moved the portable monitor 6 inches to the left, which was the position she had decided would signal to Bev that she needed her near the nurse's station rather than in the back rooms. She wheeled the chair back, got the patient seated, began the standard assessment. The man's name was given as Walter Goss, date of birth that put him at 47. His vitals were unremarkable. His chest pain, on detailed questioning, had the specific character of anxiety rather than cardiac, tight, positional, varying in intensity in ways that cardiac chest pain doesn't. He was sweating, but the temperature in the waiting room was warm and he was wearing a heavy jacket. She placed him in Bay 4 and ordered the standard chest pain workup, then went to the nurse's station where Bev was standing with a chart in her hand pretending to review it. "2 men with the patient in Bay 4, Claire said quietly. "They cleared the room when they walked in. I need you to call security. Not urgently, not a code, just a routine request for a security presence in the ED. Tell them we've had some difficult family behavior this morning." Bev didn't ask why. She reached for the phone. At 9:47, the 6th patient of the morning arrived by ambulance. The call had come in as a fall at a residential address. A 63-year-old male, head laceration, altered mental status. The paramedics who brought him in were ones she had not seen before, which was not extraordinary. There were multiple ambulance services contracted to the county. But she noted it. She noted the unit number, which she didn't recognize. She noted that one of the paramedics, a woman, kept her head turned slightly away from the overhead cameras during the handoff. The patient was transferred to Bay 6. Claire received the handoff report from the female paramedic, while the male paramedic stayed at the door, and the report was clinically adequate: vitals, mechanism, interventions. But there was something off in the delivery of it, something slightly too rehearsed, the pauses in wrong places, the technical language slightly too precise in some areas and slightly too vague in others, the way a script sounds when the person delivering it has memorized the words but not the meaning behind them. She confirmed the handoff, turned to begin her assessment, and the female paramedic left the bay. What she found when she actually looked at the man in Bay 6 stopped her for just under 2 seconds, long enough to register the information, process it, and decide what to do with it. The laceration on his scalp was real. The altered mental status was real. But the injuries that surrounded those presentations were not consistent with a fall. The man's hands were abraded in a pattern she recognized, restrained recently with something narrow and tight. There was bruising on his torso under his shirt that was 3 to 4 days old. His right eyelid was swollen with a hematoma that had nothing to do with a fall at a residential address. And she recognized his face. Not personally. Not from Delmont or from the hospital or from any context she could name immediately, but from a photograph, a Federal Protective Detail photograph that had been attached to a briefing document she had been shown in 2019 as part of the intelligence debrief following Carmel Pass. One of several individuals being moved through secure channels who had information about the operation. She had seen his face once in a photograph 7 years ago, and she was looking at it now in Bay 6 of Harlow County General, and he was trying to tell her something. His lips were moving. His altered mental status was real, but not total. He was conscious enough to know where he was, or to know that where he was mattered. He was looking at her face, at the scarring on her neck, with an expression she couldn't immediately read. She leaned in close, keeping her body between him and the door. "I'm a nurse," she said very quietly. "You're in a hospital. You're safe." His voice was barely there. He said one word, maybe two. She caught only part of it before the monitor alarm went off, and the overhead speaker activated, and everything changed. The alarm was not from Bay 6. It was from the nurse's station, a manual alarm, the kind that required a physical button press, the kind that Bev would press only if she had no other option. The overhead system announced a security response to the emergency department, and simultaneously, the lights in the corridor flickered. Not a power failure, something more targeted. A single bank of fluorescents cutting out in the hallway that led from the ED to the main hospital elevators. And the 2 men from Bay 4 were no longer in Bay 4. Claire straightened up. She looked at the man in Bay 6 and made a decision that took less than 1 second. "Don't move," she said. "Don't call out. I'm coming back." She went to the door of Bay 6 and looked into the corridor. The two men from Bay 4 were moving toward the stairwell at the end of the hall. Not running, not drawing attention, just moving with purpose. The way people who know exactly where they're going and exactly what they're going to do when they get there look when they're in a civilian space and need to stay invisible for 30 more seconds. The stairwell they were heading toward opened on the 4th floor. Room 418. Claire looked at it, looked at the door to Bay 6, looked at the security guard who was coming through the ED entrance at the far end of the corridor in response to Bev's alarm. One guard, older, not fast. She made a second decision. She went after them. Not running. Nurses didn't run in hospital corridors unless there was a code, and running would change the calculus of everything, would make them move faster, might trigger something she wasn't ready for. She walked fast, professional, the pace of someone with a task and a destination, and she went through the stairwell door 12 seconds behind the two men from Bay 4. The stairwell was concrete and fluorescent and cold. She heard footsteps above her ascending, and she started up, one hand on the railing, moving fast now, because she was out of sight, and speed was the only thing that mattered. She was on the 3rd floor landing when she heard something that stopped her. Not footsteps, but a different sound. Below her. The exterior door at the base of the stairwell, ground level, opening. She stopped, looked up, looked down. There were 3 of them, not 2. The 2 she had followed were above her, and there was a 3rd coming in from outside, and the position she was in, middle of the stairwell, between floors, 3 flights of concrete, and a metal door in each direction, was not a good one. She kept moving up. The 3rd floor door was locked from the stairwell side, restricted access, physicians and security only. She bypassed it with the maintenance override code that Bev had given her 6 months ago when they'd been trapped on the wrong side of it during a particularly chaotic overnight shift. The code was technically not for her access level, and she had never mentioned to anyone that she knew it. She came out on the 3rd floor corridor, pulled the stairwell door shut behind her, and moved toward the internal elevator bank. The elevator was at the 4th floor. She hit the call button and waited the longest 12 seconds of the morning and stepped in and went up. The 4th floor corridor was quiet, in the way hospital corridors are quiet at 10 in the morning on a weekday. A few staff members at the nursing station, the ambient sound of monitoring equipment, the particular hush of a floor where most patients are stable and recovering rather than acute. Room 488 was at the far end of the east wing, and as she came off the elevator and turned toward it, she could see that the door was closed. She could also see that the 2 men from Bay 4 were not in the corridor, which meant they were either in 418 already or they hadn't made it up yet. She walked to 418 and knocked once, professionally, and opened the door. The man inside, Raymond Dole, according to the chart, looked up from the hospital bed with the specific alertness of someone who had been expecting, for a long time, that a door would open and what came through it might not be good. He was in his early 50s. He had been well built once and was thinner now in a way that suggested recent hard months. There was a federal marshal seated in the chair by the window, hand already moving toward his jacket. "Nurse," Claire said, loudly enough for clarity, raising both hands slightly. "Harlow County General, I'm one of the floor staff." The marshal stopped moving but didn't relax. "There are 2 men heading to this room via the stairwell," she said. "I followed them from the ED. There's a 3rd incoming from the exterior ground level. I don't know if they're armed." The marshal was on his radio before she finished the sentence. What happened in the next 90 seconds happened fast enough that the sequence of it compressed in her memory into something non-linear. The marshal moving the patient toward the bathroom, Claire pushing the overbed table against the door, the sound of footsteps in the corridor outside arriving before the marshal's backup could get there, and then a different sound entirely. Multiple sets of feet, fast, the particular cadence of people moving tactically rather than casually, and then voices in the corridor, commands, short and hard. And the door to 418 opened not from the men she had followed, but from 3 individuals in tactical gear, weapons drawn, who entered the room in a stack and cleared it in 4 seconds, and the lead operator turned to look at Claire with an expression that moved from threat assessment to recognition to something she couldn't immediately categorize. He was younger than she'd expected, maybe 30. He had the particular physical economy of someone who had spent years learning not to waste motion, and he looked at her face, at the scarring, at her, and his expression shifted in a way that was small but unmistakable. "You're the one who called it in?" he said. "I followed 2 contacts from the ED. 3rd entry point was the exterior stairwell ground level. We have them. He was already moving, gesturing to his team, organizing the room. The witness is secure. We're extracting. There's another patient, she said. Bay 6 ED. He arrived by ambulance 12 minutes ago. The paramedics who brought him in, one of them kept her face off the cameras. He has injuries consistent with recent restraint, and I think he's... Name? The operator said. She told him the patient's name from memory. The operator stopped moving. He looked at her. Something crossed his face that was not quite surprise, more like the expression of a man who had been running a calculation and had just received an input that changed the answer entirely. That man is supposed to be dead, he said. We listed him 3 months ago. The radio on his vest crackled and a voice came through it, and whatever it said made him turn immediately toward the door, one hand raised to his earpiece, and Claire heard a single word clearly before the transmission broke up. Breach. The word came through the radio like a stone dropped into still water, and the ripples moved fast. The operator, she still didn't have his name, turned from her and spoke in rapid clipped exchanges with whoever was on the other end of his earpiece, and Claire watched his face and read what his face was doing the way she read vital signs. Not what was said, but what the body did while it was saying it. The jaw set. The eyes went flat in a specific way. His left hand moved to the rifle sling across his chest and adjusted it without conscious thought, the way hands move toward things they trust when the situation gets worse. How bad? She said. He glanced at her, a quick calculation. Then, they're in the building, multiple points, basement and second-floor service corridors. He was already moving toward the door. The ED is compromised. We need to move the witness now. The other patient, she said. Base A6, he's not ambulatory. We don't have the personnel to... He's a witness, she said. You said he was listed dead. That means he's been in their custody. He has information you don't have or he wouldn't still be alive. She said it fast and flat, not arguing, just laying the logic out where he could see it. They kept him for a reason, which means whatever he knows is worth protecting. The operator's radio crackled again. He pressed the earpiece harder, listening, and his expression did something complicated. My team is handling the secondary breach, he said. I have one operator with me and a marshal. He looked at the man in the hospital bed, Raymond Dole, the protected witness, who had listened to this exchange with the focused calm of someone who had been in dangerous situations long enough to know that panic was a luxury, and then back at Claire. Can you get to Bay 6 and secure that patient without my support? She thought about the stairwell, the locked third-floor door she'd already bypassed once, the service corridor configuration she had memorized during drills and confirmed in her 6 a.m. walkthrough. Yes, she said. Don't use the main elevators. Don't use the east stairwell. That's where we have contact. The west maintenance stairwell opens on the ground floor near radiology. Use that. I know it. He looked at her for one more second, that same unreadable expression, and then he turned to his remaining operator and the marshal and began organizing the witness extraction with the efficiency of someone who did not have time to waste on any variable that wasn't immediately necessary. Claire left room 418 at a walk that became something faster the moment she was in the corridor and away from anyone who might read it incorrectly. The fourth floor was still quiet. Whatever was happening below hadn't broken surface here yet, and she needed to use that. She went left instead of right, away from the main nursing station where staff would be starting to register that something was off. A security call that hadn't been resolved, a ward that wasn't responding to intercom checks, and found the west corridor that led to the maintenance stairwell. The door was heavier than the public stairwell doors, industrial, with a push bar and a hydraulic closer that made it whisper shut behind her rather than bang. She went down fast, hand on the railing, not running but close. The particular descent of someone who knows stairs and knows her own body and knows that a turned ankle at this exact moment would be a problem she couldn't absorb. Second floor. First floor. She pushed through the ground-level door and came out near the radiology suite, which was on the west side of the building and separated from the main emergency department by a corridor and 2 badge access doors. The corridor was empty. She badged through the first door. It opened. She moved through, badged the second. It opened. She came out on the south side of the ED, behind the medication room, and she could hear it now. Not sirens, not alarms, but voices at a pitch, and in a configuration that told her the department had shifted from normal operations into something it didn't have a protocol for. She went to the medication room door and looked through the narrow, reinforced window. The ED floor was wrong. She could see Bay 4, empty, curtain pulled back, equipment undisturbed. She could see the nurse's station, where Bev was standing with two other nurses, body language tight, eyes moving toward the main corridor entrance and back. She could see the two remaining security guards positioned near the ambulance bay doors, which told her the department had implemented its basic lockdown procedure: keep people in, keep unknowns out. But the lockdown had been designed for a combative patient or an external threat trying to get in, not for something that was already inside. She could not see Bay 6 from this angle. She moved. She went along the back corridor, past the supply room where she had repositioned equipment 6 hours ago, and came around the partition that separated the supply corridor from the bay area and got her first look at Bay 6. The curtain was half drawn, the monitor was still running. She could see the edge of the bed and the lower half of a figure in the bed, and nothing else. No one standing in the bay. No staff, no threat, no one. She went in. The man she had left there, the one who was supposed to be dead, whose name the operator had reacted to, was still on the bed. He had not moved. He could not move, she understood now more fully than she had before. The altered mental status was real, but it was layered. There was something chemical underneath it, something that moved like sedation but wasn't quite, and he was watching her come in with eyes that were present but slow. "I'm back," she said, keeping her voice low. "I told you I would be." His lips moved. The same word as before, or something like it. She leaned in. "Merit," he said. Almost no sound to it, but she was close enough now. She pulled back and looked at his face. "You know who I am." The faintest movement that might have been a nod. "I'm going to move you," she said. "It's going to hurt. I need you to stay as quiet as you can." She had been doing a simultaneous physical assessment since she walked back in, tracking his breathing, his color, the quality of his responsiveness. And the picture wasn't good. His systolic was low enough to be concerning, his respiratory rate was compensating for something, and his pupils were slightly unequal, which was either a pre-existing condition she hadn't had time to establish, or it was new and it was bad. She needed him moved, and she needed him assessed by someone with more resources than a curtain bay in a compromised emergency department. The hospital had a trauma room off the main ED that was used for the highest acuity presentations. A fully equipped space with separate access from the ambulance bay, its own supply cache, crash cart, and ventilator. It was 30 feet away, and it had a door that locked. She went to the bay door and looked out. The corridor between her and the trauma room was clear for 20 feet. Then it turned, and past the turn she didn't have visibility. She went back in, disengaged the bed's wheel locks, and began moving it toward the door. The bed was heavy and unwieldy in the way hospital beds always were, designed for stability rather than maneuverability, built to hold a person safely and not to move quickly through tight spaces. She got it angled through the bay opening and into the corridor, using her body weight against the frame, and she was focused on the logistics of the turn when she heard footsteps. They were coming from the direction of the main ambulance entrance, which meant they had either gotten through the lockdown doors or they had a credential that bypassed the lockdown. Neither option was good. She moved faster. The bed complained against the linoleum. She turned the corner, pushed hard, covered the remaining distance in what felt like too long, and was probably 12 seconds, and hit the trauma room door with her hip and her shoulder simultaneously, and it opened and she pushed the bed through. She locked the door from inside. She stood still for 4 seconds, listening. The footsteps passed the trauma room door without slowing. She let out a breath she had not been aware of holding and turned to the man on the bed. His eyes were open. He was watching her. Whatever was in the sedation, or whatever he'd been given, was fighting with the part of his brain that understood the situation well enough to want to stay alert, and that part was working hard. "I need to know your injuries," she said, "and I need you to talk to me if you can." "Ribs," he said. "Left side, 3, maybe 4. "How long ago?" 4 days. A pause, the effort of it visible. "They moved me twice, kept me—" He stopped, swallowed. "What's your name?" she said. Not the name on the chart. He told her. It was not a name she had a file for, but it had the shape of a cover identity, the way certain combinations of sounds get constructed for plausible deniability, and she accepted it. "What do they want from you?" she asked, beginning her physical assessment in parallel, palpating his abdomen, checking his extremities, running her hands over his left lateral chest wall where he'd indicated. He flinched hard when she reached the fourth and fifth ribs. Testimony, he said through his teeth, about the operation, about who authorized it. Carmel Pass. His eyes sharpened slightly through the haze. You were there. I was there. He stared at her for a moment with an expression she couldn't fully read. Not surprise, more like a man who had been carrying a weight for a long time and had just discovered the terrain was different than the map had shown. The convoy, he said. Yes. I didn't know, he said, about the ambush. Not until after. What they were using the corridor for. I had access to parts of the operation, but not that part. When I found out, he stopped again. His breathing was effortful and she could hear it now, a quality in it that she didn't like. A slight restriction that could be musculoskeletal from the rib fractures or could be something building underneath. Don't talk more than you need to, she said. I need you breathing efficiently more than I need information right now. She pulled the crash cart away from the wall and opened the supply drawers. Not because she was at that point yet, but because she wanted the inventory visible, wanted to know exactly what she had and where it was before she needed it. Oxygen was on the wall, suction available. She pulled a nasal cannula from the drawer and got it on him at 2 liters, because his saturation was reading 93 on the portable pulse ox she'd clipped to his finger. And 93 was not an emergency, but it was a number that pointed in a direction she needed to point it away from. His saturation came up to 95. Then 96. She watched the number and watched his breathing. They're trying to get to the other witness, he said. We know. He's being extracted. Something moved across his face. Both of us testify. It's enough for the whole network. Not just the field operators, the people who approved it. Bureaucratic level. He met her eyes. That's why they kept me. I have documentation they don't know about. Digital. I encoded it and stored it, and the only person I told was a federal agent who... He stopped. Who's been dead for 6 weeks. The trauma room was very quiet. She heard something in the main corridor. Not footsteps this time, something different. A sound that was out of place in a hospital environment in a way that took her 1 full second to identify, because the last time she'd heard it, she had not been in a hospital. It was the sound of a suppressed weapon firing. Not loud. Not the thunderclap of an unsuppressed gunshot, which would have been immediately identifiable to everyone in the building. A suppressed weapon in a hospital corridor sounded almost like a door slamming badly, or something heavy falling, and she thought distantly that this was probably how they had planned it, designed to be misidentified, to buy them an extra 30 seconds before the building understood what was happening. 30 seconds was a long time if you knew what to do with it. She went to the trauma room's secondary phone, wall-mounted, direct line to the main nursing station, and picked it up. Bev answered on the first ring. It's me, Claire said. Do not open the ambulance bay doors for anyone you haven't personally verified. Keep your staff behind the station. I need you to call a lockdown code right now, full facility, not just the ED. Claire, what is... Code Silver, she said. Call it now. And tell me how many staff are unaccounted for. She heard Bev pull the breath in. Heard the moment when 19 years of experience in emergency nursing overrode every instinct to ask questions. And then she heard Bev's voice change, become the charge nurse voice, the one that carried authority and clarity and no room for argument, as she reached for the overhead system. Code Silver at Harlow County General was the hospital's active threat protocol. It had been practiced twice in Claire's 14 months at the facility. The overhead announcement would lock all exterior doors automatically, push all non-emergency staff into lockdown positions, and alert the county sheriff's department. The overhead system activated. She hung up and went back to the man on the bed. I need that documentation, she said. The encoded files. Where are they? I can't access them from here. Where are they stored? A server. There's an access code. He met her eyes. I'll give it to a federal agent. Not before. She looked at him. She understood the logic and she respected it. A man who had survived whatever the last months had been by being careful about exactly this kind of decision was not going to undo that caution because a nurse in a trauma room asked him to. Fair enough, she said. The door handle moved. Not a knock. Not an attempt to badge in. Someone had a hand on the door handle and was applying pressure to it, testing it, confirming it was locked. She watched the handle move 1 millimeter, 2, and then stop. She positioned herself beside the door, not in front of it, not where someone breaching would expect a person to be. and picked up the laryngoscope from the crash cart, which was the heaviest instrument immediately available to her, and held it in her right hand and waited. The door didn't open, the handle stilled. She waited 10 seconds, 20, 30. Nothing. She went back to the bed. The man was watching her with eyes that had more in them than the sedation should have allowed, fighting toward clarity with everything he had. "There are cameras in this room," he said. She looked at the camera mounted in the upper corner, which she had registered when she entered. "Standard hospital monitoring, routed to the security office." "The security office is part of the lockdown," she said. "It should be," and then she stopped, because she was thinking about the lights on the 4th floor, the way a single bank had cut out in a targeted way rather than a broader failure. And she was thinking about the paramedic who had kept her face away from the overhead cameras. And she was thinking about the access that someone would need to cut specific cameras in specific corridors while leaving others functional. And that kind of access didn't come from outside the building. It came from inside it. "Someone on the inside has system access," she said, and heard her own voice say it with the particular flatness of a statement that has just become a certainty. She moved to the camera in the corner and did something she had never done in 14 months at this facility. She unplugged it from the wall junction with her bare hands, which broke the housing slightly and would require an explanation later. And she did it because the only people watching a compromised camera feed in a compromised security office were people she did not want watching. The room felt smaller after that. She checked the man's vitals again. Blood pressure had dropped another 4 points, saturation holding at 96, respiratory rate at 22, which was elevated but not critical. The rib fractures were his primary mechanical problem, and there was nothing she could do about that in this room beyond what she'd already done. She needed a physician, and she needed imaging, and she needed a situation where she could actually get him either of those things. Her phone buzzed. She pulled it out, Calloway's number. "Where are you?" Calloway said without preamble. "Trauma room, ground floor. I have the secondary patient. He's alive and he has documentation the network doesn't know about." She kept it brief. "Someone inside the hospital has network access to the security systems. At least one compromised staff member or a credential that's been cloned. The camera feeds for the south corridor are being selectively managed. How many hostiles are you tracking?" "I had eyes on 3. I don't know if there are more." She moved to the trauma room's narrow interior window, which looked out onto the ambulance bay. "Calloway. The extraction team. They were ahead of this breach. Are they clear?" "Witness 1 is in a secure vehicle. Extraction completed 4 minutes ago." A pause. "We have a situation with the second team. We lost radio contact with Carver, the operator you met. Last known position was the 2nd floor service corridor. The ambulance bay was empty. The lockdown had cleared it. No vehicles, no personnel. The exterior doors were sealed. Through the reinforced glass, she could see the parking lot beyond, ordinary and undisturbed, and the contrast of it with what was happening inside the building had a specific quality of surreality. "I'm going to the 2nd floor," she said. "Merritt, I know this building. Your operator doesn't. Tell me his last position and tell me which corridor." Calloway gave it to her without further argument, which told Claire something about how the operational calculus had shifted in the last few minutes. She looked at the man on the bed. She pulled the call cord from the wall and tied it around the crash cart, anchoring it across the interior of the door. Not a proper barricade, nothing that would stop a determined entry, but something that would slow it and make noise and buy time. She set the saturation monitor to alarm at 90 and put the pulse ox on his finger. "If that alarm goes off and I'm not back," she said, "use the wall phone. Call the nursing station. Bev Okafor. She will come." He looked at her. "You're going up," he said. "Yes." "Be careful with the east side," he said. "The one with the mark on his hand. He favors his left. He'll come from your right." She stopped. "You've seen them?" "For 3 months," he said. "I've had nothing to do but watch them." She absorbed that, thanked him with a nod rather than words, because words took time, and went out through the trauma room's secondary exit. A door she had confirmed during her 6 a.m. walkthrough opened onto the internal service corridor rather than the main ED floor. She moved through it and found the hospital's internal geography the way she had found it in the dark during drills, not by thinking about it, but by having put it in a place in her memory where it lived below the level of conscious navigation. She went up through the maintenance stairwell, past the 1st floor landing, past the second floor door, which she stopped at. She listened. There was sound on the other side. Not the normal ambient texture of a hospital floor. That had a rhythm to it, a predictability. This was irregular. Movement in bursts, then stillness. She tried to count from the sound. 2 people, maybe 3. The service corridor on the second floor ran along the north side of the building and accessed the facility's utility infrastructure, HVAC, electrical distribution, server room, where the security camera feeds routed through. The server room. She pushed through the door. The service corridor was narrow and fluorescent and smelled of whatever industrial cleaner the maintenance crew used. She moved along the left side, keeping her shoulder close to the wall, and went toward the utility block where the server room was located. The door to the server room was open, not ajar. Open. Fully, deliberately, the kind of open that meant someone had decided they no longer needed to be subtle about it. She came up to the door frame and looked in. The operator, Carver, was on the floor inside the server room, back against the equipment rack, and she ran a rapid assessment in the second she had to do it. Conscious, left arm held close to his body in the way you hold something that's damaged but hasn't fully announced its damage yet, a cut above his eye that was bleeding steadily into his vision. He registered her presence, and his expression moved through several things quickly. One of the server room's terminal screens was active, running through something. She couldn't read it from the doorframe, but the pattern of it looked like an access cascade, someone pushing through multiple authentication layers. And beside the terminal stood a man she had never seen before, but whose physical description matched precisely what Dana Calloway had described to her in the 4 a.m. call. 50, Eastern European, scar on the left temple, missing the tip of his right index finger, which was evident as he worked the keyboard. He had not seen her yet. I was focused on the terminal, and there was a quality of concentration in his posture that said he was close to whatever he was trying to do. Close enough that his situational awareness had narrowed, the way it does when you're almost finished with a task, and the task is pulling your attention forward. She had seconds. She assessed the room. The man's weapon was holstered. Carver was between her and the man, 8 feet of cluttered server room floor. The terminal screen was running the access cascade, and she didn't know what it was accessing, but she knew that whatever it was, the moment it completed, the operational situation changed in ways she couldn't control. She looked at Carver. He looked at her. He moved his good arm slightly. A minimal gesture, almost imperceptible, but she read it. Right side. She remembered what the man in the trauma room had said. He favors his left. He'll come from your right. She stepped into the server room. The man heard her. He started to turn. She crossed the distance faster than the room suggested she should be able to, put her shoulder into him before his hand reached his holster, and they went into the equipment rack together, and the rack moved and the terminal screen flickered. He was larger than her, heavier, and he recovered faster than she'd hoped. Got a hand on her left arm, the scarred arm, and she felt the grip on old scar tissue and the particular pain of that, which was different from the pain of injury, and she used the second of his leverage to drive her elbow into the junction of his neck and shoulder and put everything she had behind it. He went down, not out. I went down and started coming back up, and she was already at the terminal, hitting the sequence she'd watched on the screen. Not the access sequence, the termination sequence, the abort. 2 keystrokes that cleared the authentication stack before it could resolve. And then Carver was there, somehow upright, and between them they managed what neither of them could have done separately. And the man with the missing fingertip went still on the floor of the server room with zip ties that Carver produced from somewhere on his tactical rig, and Carver sagged against the rack and pressed his good hand against the cut above his eye and breathed. The terminal screen had gone dark. Left arm, she said, reaching for it. It's fine. Let me look at it. He let her look at it. Displaced fracture of the radius, she was nearly certain. The deformity was subtle but present, and the way he'd been guarding it. She told him, "Can I move on it?" "Carefully. You're going to need imaging and reduction today." "After," he said. "After," she agreed. She zip-tied the man's arms herself, pulling the restraint snug and checking the circulation below it the way she checked IV sites, systematic and thorough, because she wanted him secure and she also wanted him intact enough to be interrogated, and those 2 requirements had to coexist. Her phone went off. She pulled it out. Not Calloway. The hospital's internal extension. The trauma room. She answered. It was not Bev. It was a voice she didn't recognize, male, and what it said in 6 words emptied everything else from the room. "Your patient isn't in here anymore." She stared at the phone for 1 second. Not paralysis, processing. The voice on the other end was male, calm. In the way people are calm when they want you to understand they have control of the situation. And 6 words was exactly the right amount. Enough to communicate the fact, not enough to give her anything she could use. She hung up and called Calloway. "Trauma room is compromised," she said the moment the line connected. "Secondary patient is mobile. Someone moved him. I need eyes on the interior. Do you have any functioning camera feeds?" "We're working on restoring the south corridor feeds now. The server room breach set us back." A pause, voices in the background. "We have partial coverage. Loading dock camera is live. What am I looking for?" "Male patient, mid-50s, hospital gown, nasal cannula, probably still attached, altered but ambulatory. He was sedated, he can't move fast, but someone is moving him." She was already heading for the server room door, speaking and moving, Carver pushing off the equipment rack beside her. "Whoever called me from that trauma room had access to the internal phone directory. That's not a network asset who came in from outside. That's someone who knows this building." Calloway's line went quiet for 2 seconds that felt longer. Then, "Loading dock camera shows a figure in a hospital transport uniform moving east along the interior service road. Wheelchair. Patient in it." Another pause. "There's a vehicle at the east service gate. It's been there 11 minutes. We flagged it as maintenance earlier." "It's not maintenance." "No," Calloway said. "It's not." Claire was already at the maintenance stairwell. "How long until you have personnel at the east gate?" 7 minutes minimum. County sheriff is holding the perimeter, but they don't have authorization to breach the gate without— 7 minutes is too long, she said, and went down the stairs. Carver came with her. She didn't tell him not to. He was injured and should have been stationary, and he came anyway, broken radius and all, which she registered and moved past because she didn't have the luxury of arguing with him about it, and because the truth was that having him behind her changed the tactical picture in ways she needed. He held his weapon one-handed with the competence of someone who had clearly trained for exactly this contingency, which was grimly practical and not something she commented on. The ground floor. The service corridor. She went east, the direction the loading dock camera had shown, and the corridor here was longer and less familiar. She had walked it during her 6 a.m. assessment, but not memorized it the way she'd memorized the ED layout, and she made herself slow down enough to read the signage on the doors rather than guess. Biomedical engineering, environmental services, linen storage, east service exit. She heard the wheelchair before she saw it, the squeak of a wheel that needed lubrication, the specific pitch of hospital transport equipment, familiar from 14 months of pushing beds and chairs through this building, coming from around the corner ahead of her. She stopped, held up a fist. Carver stopped behind her. She listened. One set of footsteps pushing. No conversation. The patient was not speaking, which meant he was either unconscious or had been told to be silent, and she didn't know which. She went around the corner. The transport aide was a woman she did not recognize, not in hospital scrubs, in the kind of generic uniform that reads as hospital from a distance but isn't, the particular shade of blue-gray slightly off from what Harlow County General actually issued. She was in her 30s, compact, and she had the patient, her patient, the man from the trauma room, in the wheelchair with a hospital blanket over his lap, and the nasal cannula still running to a portable oxygen cylinder attached to the chair back. The woman saw Claire at the same moment Claire saw her. For a half second, neither of them moved. Then the woman let go of the wheelchair and ran for the service exit door at the end of the corridor, and Claire let her go. The calculation took no time at all. The patient mattered more than the runner, and Carver was behind her. She heard him speak into his radio as she went to the wheelchair. The man in it was conscious, barely. His saturation alarm was sounding from the pulse ox still clipped to his finger, 88%, which was the number that had been set to summon help and hadn't been able to summon it because he wasn't in the trauma room anymore. His color was wrong, a gray-blue tinge that she identified in the half-second of assessing his face before she began working. The oxygen cylinder on the chair was still flowing. She checked the nasal cannula. It had been displaced, sitting across his cheek rather than in his nostrils. She repositioned it, checked the flow rate, increased it to 4 liters. She counted his respirations, 17 per minute, shallow. "I need you to take slower breaths," she told him. Bigger ones. You're compensating for the pain. I know. Take them anyway. He tried. She watched his chest rise and fall, watched the saturation reading on the pulse ox, and 88 climbed to 90 and then stopped. The ribs, he said. He stopped. They moved you roughly. Yes. She palpated his left lateral chest with as much care as the situation permitted. He couldn't suppress the sound he made when she reached the fourth rib, and she felt under her fingers what she hadn't been able to fully characterize during her earlier exam. The specific movement of a fracture segment, a section of rib that was no longer behaving as part of the intact chest wall. Flail segment. Small, probably 2 ribs, but enough. Okay, she said quietly. Here's what's going to happen. I need you to stay as still as you can. I'm going to get you back to a room with more equipment. How bad is it? She looked at him directly. Manageable, but I need to manage it properly, and I can't do that here. He accepted that with the economy of a man who had learned not to spend energy on things he couldn't change. Carver appeared at the end of the corridor. Runner is contained. She went into the east stairwell and ran into County Sheriff coming up from the outside. He stopped when he saw Claire's face. How bad? Flail segment. I need this man in a room with a ventilator and I need a physician. She started pushing the wheelchair back the way she'd come. Call Calloway. Tell her I need the trauma room cleared and I need a chest surgeon notified. Carver was already on his radio. What followed was the particular texture of a crisis that had moved from active and acute into the phase where the immediate physical danger had been addressed. And what remained was the work. The careful, methodical, unglamorous work of managing a body that had been through too much and needed precise intervention to come back from it. She got the patient back to the trauma room. She found Dr. Voss there, of all people, which she had not expected. He had come down from wherever the lockdown had placed him, with the expression of a man who had spent the last 40 minutes receiving information in pieces and was not enjoying the picture it was assembling. He looked at the patient. He looked at Claire. He looked at the saturation reading. What do you have? He said, and the tone of it was different from the tone of yesterday's corridor. It was the physician voice, unadorned, purely functional. She gave him the handoff in 30 seconds. Mechanism, timeline, suspected flail segment, current vitals, respiratory compensation pattern, oxygen response. He listened without interrupting, which was new, and then he moved to the patient and began his own assessment. Get me a portable chest x-ray, he said, and get thoracic surgery on the phone now. She had the x-ray ordered before he finished the sentence. The next hour did not resolve cleanly. It moved in the way medical situations move when they are serious but survivable, with setbacks and adjustments and moments where the trend went the wrong direction before it went right. The thoracic surgery attending arrived, a compact woman named Dr. Priya Sarin, who had been in the middle of an elective case when the lockdown hit, and had been paged the moment Carver's call reached Calloway's team. She reviewed the imaging, confirmed the flail segment, made decisions about pain management and respiratory support that were precise and unhesitating, and within 20 minutes, the patient's saturation was sitting at 97 on high-flow oxygen, and his breathing had steadied. Claire stood outside the trauma room door and felt the adrenaline begin its exit from her body, which was not pleasant. It never was. The exit was worse than the arrival. The arrival kept you functional. The exit reminded you of everything your body had been doing to stay that way. Calloway arrived in person at 11:40 a.m. She was shorter than her voice had suggested, mid-40s, dark-haired, wearing a suit that said Federal even without the badge she had clipped to her lapel. She came through the ambulance bay with 2 additional agents and went straight to Claire, which told Claire something about how the operational picture had shifted. Debrief, Calloway said. Here? Hallway is fine. I need your account before we process the detainees. Claire gave it to her. The whole sequence, start to finish, in the order it had happened. She did not editorialize. She did not emphasize her own role beyond what the facts required. She gave Calloway the account the way she had given after-action reports in the Army, sequential, accurate, complete, without performing it. Calloway listened to all of it without writing anything down, which meant she was recording it. The server room, Calloway said when Claire finished. You terminated the access cascade before it resolved. Do you know what he was trying to access? Camera system, based on what I could see of the interface. My best assessment was that he was trying to either archive or delete footage from specific corridors. I was trying to delete it, Calloway said. The footage from the south corridor and the service entrance that would have put 3 of our 6 detainees inside the building before the breach. She paused. You kept the evidence intact. Claire said nothing. You also kept a witness alive who had been reported dead for 3 months, Calloway continued, who has, in the last 20 minutes, given my agent the access code for an encrypted server archive containing operational documentation for the Serova network going back 8 years. She held Claire's gaze. That documentation names the individuals who authorized the Carmel Pass ambush. The corridor was noisy, hospital lockdown noise, the specific busy sound of a building, returning to itself after a disruption, staff moving and voices overlapping and equipment rolling across linoleum. Claire stood in the middle of it and let what Calloway had just said sit there for a moment. Names, Claire said. 14 individuals, 11 of whom are currently living in the United States. 3 of whom hold or recently held federal contractor positions. Calloway's expression did not change, but something in it tightened. The ambush wasn't a rogue operation, Merritt. It was authorized at a level that has, up until approximately 45 minutes ago, been protected by the network's ability to suppress witness testimony and eliminate evidence. The hallway felt different after that. Not physically, but the information restructured the space, the way information sometimes did when it was large enough. It changed the proportion of things, made the linoleum floor and the fluorescent lights and the sound of a blood pressure cuff cycling somewhere down the hall simultaneously ordinary and insufficient, the wrong scale for the thing being discussed. The hospital administration, Claire said. It came out quieter than she intended. Calloway looked at her carefully. What about them? Sandra Pruitt was admitted through this facility. The proximity assessment the network ran on me was run through this facility. The internal phone directory access, the security credential that was cloned to manage the camera feeds, that required either active cooperation from someone with administrative-level access or a significant intelligence effort to obtain it. She held Calloway's gaze. I want to know if there was cooperation. Calloway's expression said she had already been asking the same question. We're pulling administrative access logs from the last 6 months, she said. Security credential issuance records. It'll take time. How much time? Days, maybe less. A pause. Why? Do you have a specific concern? Claire thought about Harlan Voss and the way he had stood in the corridor that morning and said good catch with the specific quality of a man recalibrating rather than a man apologizing. She thought about the credential that had accessed the lockdown override and the camera management system, administrative-level access, Calloway had confirmed, and she thought about who in this building had administrative-level access to those systems, and the motive structure that might explain why a proximity assessment on a former combat medic had been allowed to proceed inside these walls without triggering any internal alert. Not a specific concern, she said. An observation. Calloway wrote something on her phone. Noted. The federal investigation moved into Harlow County General with the particular thoroughness of a federal investigation that has been waiting months for an opening. Evidence technicians, agents conducting interviews with staff, a forensic IT team that spent 4 hours in the server room and came out with hard drives and expressions that said they had found what they were looking for. The 6 detainees, 4 from inside the hospital, 2 from the exterior, were processed and transported. The woman in the incorrect blue-gray uniform was identified as a contracted intelligence asset with a history that went back significantly further than her recent employment and was not, in any sense, incidental. Carver had his radius set in the same ED where he'd been operating that morning, by a physician who was professionally obligated not to comment on the circumstances that had produced the fracture and visibly struggled with this constraint. He was in a cast and a sling by early afternoon and appeared at the nurse's station where Claire was completing the documentation she had not been able to complete during the preceding 6 hours. Your documentation, he said, looking at what she was writing. Incident report, she said. Patient care records. Timeline. She kept writing. There are patients in this hospital who received substandard care this morning because the staff was in lockdown and I was occupied with other things. That needs to be documented accurately. He watched her for a moment. You know, most people in your position would be writing documentation, she said. He almost smiled. It didn't quite get there, but it was close. There's going to be a formal debrief, probably tomorrow. Calloway will want you there. I know. She's also going to request your personnel file, the classified sections. She can request them, Claire said. That decision isn't mine. He nodded. Then, with the slight awkwardness of someone who had been trained for most situations but not quite for this one, the man downstairs, in the trauma room, he asked about you. She stopped writing. He said to tell you, Carver checked something on his phone as though he'd written it down. He said to tell you that the people he testified against were the same people who were supposed to protect the convoy, not external threats, not the parties the ambush was attributed to. Internal authorization. He said he thought you should know it wasn't random. It was designed to silence the convoy personnel after the fact. The nurse's station was busy around her. Bev was at the far end with a chart. A tech was running a sample to the lab. The overhead system was doing its ordinary hospital things. Routine pages, department calls, the rhythmic texture of a facility finding its way back to operational normal. Claire set down her pen. She had known, on some level, since 2019. Not the specifics, not the names, but the shape of it. The shape had been wrong from the beginning, the angle of attack, the quality of the intelligence failure that had placed the convoy in that corridor, and the subsequent silence that had followed her testimony. She had put that knowledge in the same interior place she put other things she could not immediately act on, and she had left it there, and she had gone on, and she had been correct to do both. It still landed. She picked up her pen and went back to the documentation. The afternoon brought the first formal visit from hospital administration, in the form of the chief operating officer, a man named Gerald Pask, whom Claire had seen twice in 14 months, both times at all-staff meetings, where he spoke from a podium and did not circulate among the nursing staff. He came to the ED floor at 3 o'clock with the legal department's head of compliance and a HR representative, and they went first to Voss's office and were in there for 40 minutes, and then they came to the nurses' station and asked to speak with Claire. They went to the family consultation room, which was the private space the ED used for difficult conversations, and Claire sat across from Gerald Pask and did not make it easy for him, which she did not think she was required to do. We're aware of the events of this morning, Pask began, and we want to ensure that our staff are supported during— Who had administrative-level access to the security credential system? She said. A pause. The HR representative looked at the compliance officer. Pask's expression rearranged itself. That's under investigation, he said. I know it is. I'm asking if you know. Ms. Merritt, a federal protective witness was moved through this facility in a proximity assessment. The network that conducted the assessment needed internal access to do it without triggering automated alerts. Administrative access. She kept her voice level, not accusatory, just precise. The same tone she used for clinical handoffs. I want to know if the administrative access that was compromised from outside or was provided from inside. Pask looked at her for a long moment. He was not a stupid man, she thought. He had gotten where he was by reading rooms, and the room he was currently in was not reading in his favor, and he knew it. We don't know yet, he said. Honestly, the federal investigators have our access logs. We'll know more tomorrow. Then I'll be here tomorrow, she said. She stood. The meeting was over. She walked out of the consultation room and went back to the nurses' station and sat down and finished the documentation she had been working on. At 4:15 p.m., Calloway appeared at the nurses' station with an expression that was still professional but had shifted in temperature, warmer by a specific increment that Claire read as significant. Access logs, Calloway said. We found what we needed. How high does it go? In the hospital? Calloway placed a hand flat on the counter. The compromised credential was issued 6 months ago. The issuance was authorized at the administrative level, and the authorization signature belongs to— She paused. Not for drama, for accuracy. The Chief of Emergency Medicine. The name settled into the space between them. Harlan Voss. Claire sat with it. Not surprised, not exactly. The shape of it fit things she had registered and filed without knowing what they were. The particular nature of the humiliation that first morning, performed for an audience, designed not just to dismiss her, but to establish a public record of her unreliability. The pattern of her clinical concerns being suppressed through official channels. The quality review meeting where her sepsis call had been recharacterized, not just as overreach, but in language that would appear in her personnel record. A woman who could be discredited was a less credible witness. He didn't know what I knew, she said. He was suppressing me as a precaution. That's our assessment, Calloway said. The network identified you as a potential witness risk 14 months ago when you came to Delmont. They placed an asset in the hospital administration to manage you. Voss was recruited or coerced, we're still determining which, and his role was to ensure that if you ever became an active problem, there was an institutional record to undermine your credibility. The department around her continued its ordinary afternoon business. Somewhere in the building, 2 witnesses were alive. 6 network operatives were in federal custody. An encrypted archive was being analyzed by federal forensic accountants and intelligence analysts in a building somewhere that was not Harlow County General in Delmont, Wyoming. And the man who had stood in a corridor 24 hours ago and told her to cover her scars was sitting in his office 40 feet from where she was, not yet knowing that the access logs had come back, not yet knowing that the 11-year position he had treated as a permanent condition of the universe had just become a prior career. Calloway looked at her. We're going to arrest him this afternoon. I wanted you to know before we did it. Thank you, Claire said. Is there anything you need before we do? She thought about it genuinely. She thought about the sepsis patient who had survived because she had pushed. She thought about Sandra Pruitt and her Washington area emergency contact. She thought about the man in the trauma room and his careful, costly decision to keep the access code to himself until he could give it to someone he trusted. She thought about the crash cart she had inventoried by memory, the wheelchair wheel that had squeaked, the 4 seconds she had stood in the parking lot the previous evening while the snow started to fall. No, she said. Do what you need to do. They walked Harlan Voss out of Harlow County General Hospital at 4:47 in the afternoon, through the main lobby, past the reception desk and the waiting area, and the volunteers in their blue vests and the family members sitting with coffee cups and worry. And Claire was at the nurses' station where she could see the lobby through the glass partition, and she watched it without expression and without satisfaction, because this was not the part that felt like anything in particular, the part that would feel like something was still ahead. Bev appeared at her elbow, as she always did, with the accuracy of 19 years and a very well-calibrated sense of when to be present. Is it over? Bev said. The acute part. Good. Bev set a cup of coffee on the desk beside her. Terrible hospital coffee, the same as always. Then finish your documentation and go home. You've been here since 6 in the morning. I know. Do you know what time it is? Claire looked at the clock. Nearly 5. She had been in this building for 11 hours. She had in that time run a primary trauma assessment, identified a compromised security system, assisted in the containment of a federal surveillance asset, prevented the deletion of critical evidence, managed a flail chest in a service corridor, and watched the man responsible for 14 months of deliberate institutional suppression be removed from the building in handcuffs. She picked up the coffee. Bev, she said, the complete explanation I owe you. Whenever you're ready, Bev said. I have time. It's long. I brought a second cup, Bev said, and held it up. And despite everything, the shoulder, the fatigue, the particular weight of information that had been delivered to her that afternoon about what had happened in a mountain pass in 2019. And why? Claire felt something move in her chest that was small and genuine and not performed for anyone. The paperwork waited. She drank the coffee. Outside the narrow windows of Harlow County General. The afternoon was darkening toward evening, the mountains invisible again behind weather, the parking lot ordinary and lit and covered in the light snow that had accumulated through the day, and somewhere in this building a man was giving testimony that would travel from Delmont, Wyoming to courtrooms and congressional offices and classified briefing rooms whose addresses she would never know. And in the morning she would come back to this floor. She would check the census board. She would triage the waiting room. She would do the work that did not carry her name anywhere visible, that did not resolve into recognition or ceremony, that required only that she show up and be exactly what she was. She was still thinking about that when her phone rang. Calloway again. She answered. One issue, Calloway said. Voss's attorney is claiming his client had no knowledge of the network's operational activities, that the credential access he authorized was done under coercion with documentation he was told was routine. He's going to argue he was a victim of the network, not an asset. A pause. If that narrative holds, the charges reduce significantly. And the suppression of your clinical record, the quality reviews, the documentation, gets reframed as standard institutional conflict rather than deliberate witness management. Claire thought about the corridor, the audience, the 11 years of a position treated as permanent. Pull his email, she said, not the hospital server, his personal accounts. He wouldn't have communicated with the network on institutional infrastructure. She thought about the timing, the specific timing of her arrival in Delmont, the credential issuance 6 months after that. He knew what I was before I started here. The network told him, which means there was communication before the credential was issued, before the first quality review, before the first incident. She stopped. He wasn't coerced. He was briefed. A long silence. How confident are you, Calloway said. Confident enough to tell you to look. Another pause, then, we'll look. The call ended. Bev was watching her. What? Claire said. Nothing, Bev said. But her expression said something else. Something that was 18 months in the making and had finally found the shape to sit in. The particular look of a woman who had known, from the first week, that the nurse with the scars and the quiet manner was not what the administration had decided she was, and who had been waiting, with the patient practicality of someone who understands that the truth generally surfaces on its own schedule rather than yours, for the institution to catch up. Drink your coffee, Bev said. Claire drank her coffee. The personal email accounts took 41 hours. Calloway called on Thursday morning while Claire was in the middle of a shift. A pediatric asthma case. A 70-year-old with chest pain that turned out to be reflux. The ordinary machinery of an emergency department running at its ordinary pace. And the call came in on her personal phone, and she stepped into the medication room and took it. We found the correspondence, Calloway said. 11 months before you arrived in Delmont. A contact address that routes through 3 different servers, but traces back to a network communications node we've had flagged since 2021. The content is explicit. They told him who you were, what you had seen, and what they needed him to do. A pause. He wrote back within 6 hours. No coercion, no delay, no indication of reluctance. Claire stood in the medication room with the door closed and the shelves of labeled drawers around her and let that information settle into the already established structure of what she knew. 6 hours, she said. He negotiated compensation, Calloway said. Not much, which is somehow worse. The network didn't have to work hard. She thought about what 6 hours meant for a man who had held a position for 11 years and understood, presumably, what it was worth, what the institution was worth, what the people inside it were worth. She thought about the quality review meeting where the word overstepping had been used, and the morning in the corridor where the performance had been staged for the specific purpose of building a public record, and the 11 months that had preceded her first day at Harlow County General, during which Harlan Voss had known what was coming and had decided what he was going to do about it. What happens now, she said. Federal charges, wire fraud, conspiracy to obstruct justice, material support. The last one is the heaviest. Calloway's voice was matter-of-fact, the voice of a woman who had been building cases long enough to describe serious things without dramatizing them. His attorney has already indicated he'll cooperate in exchange for consideration on sentencing. That cooperation will be assessed on its actual value, not its promised value. Will it matter, what he gives you? It'll matter to his sentence. It won't matter to the outcome. The archived documentation, the access logs, your testimony, the testimony of both witnesses. It's sufficient without him. A pause. He doesn't have as much to trade as he thinks he does. That's usually how it goes. Claire said nothing for a moment. Outside the medication room door, the department continued its business. She could hear it, the controlled, busy sound of it, and she thought about the 11 months during which Harlan Voss had gone to work in this same department every day, knowing what he had agreed to. Thank you for telling me directly, she said. You're the reason we have the evidence, Calloway said simply. You're owed the information. She went back to the floor and finished her shift. The formal proceedings against Harlan Voss were not swift in the way that dramatic things in stories are sometimes swift. The law moved at its own pace, which was slower and more procedural than television suggested and more thorough than his attorney had apparently anticipated. The preliminary hearing was 3 weeks after the hospital events. Claire did not attend. She was not required to, and attending would have meant sitting in a room watching a legal process she had no ability to influence, which was not a useful expenditure of her time or her attention. Bev attended. She told Claire about it afterward with the precision of a woman who had taken mental notes. He looked smaller, Bev said. Not literally, but the way he held himself, like a man who finally understands what room he's actually in. Did he say anything? His attorney said a lot. He said very little. She paused. He looked at the federal charges document for a long time, like he was reading it for the first time even though he'd had weeks. Claire thought about that. The particular experience of a man reading the documented consequences of a decision he'd made in 6 hours, 11 months before those consequences arrived. She did not feel sorry for him. She had checked, honestly, and the answer was no, she did not. But she also did not feel the satisfaction she might have expected. The satisfaction she felt was quieter and different in character. It was the satisfaction of accuracy. The thing was now correctly labeled. The record now said what the record should say. That was not the same as triumph, but it was not nothing. The hospital board convened an emergency session 2 days after the preliminary hearing. Gerald Pask, the COO, who had sat across from her in the family consultation room with his compliance officer and his HR representative and his carefully managed expression, resigned the following morning. The board statement cited a commitment to institutional accountability, which was the language institutions used when accountability had been forced on them from outside rather than chosen from within. Claire read the statement on her phone and set the phone down and went to make coffee. The acting chief of emergency medicine was Dr. Petra Odell, who had been the department's associate medical director for 6 years, and who had, in Claire's 14 months at Harlow County General, never once commented on her appearance, never once dismissed a clinical concern without first engaging with the substance of it, and who had been in the quality review meetings and had been, according to Bev, one of 2 voices who had questioned the characterization of Claire's sepsis call as overreach before being outvoted by the Voss faction. Dr. Odell asked to meet with Claire in her first week as acting chief. They met in the office that still had Voss's medical school diplomas on the wall, which Odell had not yet gotten around to removing, and they sat across from each other with coffee and the particular slight awkwardness of 2 people who knew each other professionally but were now meeting in a different configuration. "I owe you an apology," Odell said, "for the quality review meetings. I didn't push hard enough." "You pushed," Claire said. "It's in the minutes." "Not hard enough." Claire looked at her. "You were working with the information available to you at the time. So was I. So was everyone." She meant it, not as absolution offered because it was expected, but as the actual assessment of a woman who had spent a great deal of time thinking about the difference between culpable failure and the ordinary human inadequacy of not knowing what you didn't know. Odell accepted it, though she didn't look entirely comfortable with the acceptance. "I've submitted a formal correction to your personnel record. The quality review entries have been annotated to reflect the actual clinical outcomes and the circumstances that have since come to light." She paused. "The sepsis case, the Pruitt presentation, and your role in the events of Tuesday." "The correction is appreciated," Claire said. "It should have been the record from the beginning." "Yes," Claire said, "it should have." The silence that followed was not uncomfortable. It was the silence of 2 people who had said what needed to be said and were both professional enough to let it sit without filling it with additional words that would make it easier but less accurate. "There's something else," Odell said. "The board has approved a position. It was proposed before all of this, actually, tabled because of budget concerns. And they've now reprioritized it. Director of Emergency Trauma Training. It's a new role. The intent is to build a formal advanced trauma response program for the department, integrating field-level expertise with our clinical protocols." She met Claire's eyes. "Your name was the first one proposed. That was before Tuesday. I want you to know that." Claire looked at her. "Before Tuesday." "The sepsis case went to a regional peer review board as a teaching case last month. Your clinical reasoning was the focus. It went, well." A slight pause. "Your name was already in circulation among people who pay attention to that kind of thing." She had not known that. She received the information and placed it beside the other things she had received in the last 3 weeks and let it be what it was. "Tell me what the role involves," she said. Odell told her. It was more than a title. It was a program, with a curriculum to build and staff to train and protocols to develop, and a budget that was modest but real. It was the kind of thing that required someone who understood both the clinical environment and the specific conditions under which clinical training failed when the situation exceeded the textbook. It was the kind of thing that required someone who had been in situations where the textbook wasn't enough and had learned, at significant personal cost, what filled that gap. Claire asked 3 questions. They were specific and practical and had nothing to do with the title or the recognition and everything to do with whether the thing would actually work. Odell answered all 3 without hesitation. "I need a week to think about it," Claire said. "Of course." She took 6 days. The answer she arrived at was not simple, which was how she knew it was honest. The part of her that had come to Delmont for smaller stakes, for the individual rather than the aggregate, for a scale of work that did not require her to be more than one person. That part had a legitimate claim on the decision, and she did not dismiss it. She had learned to distrust people who made large decisions easily, including herself. But there was another part, the part that had stood in the trauma room with a man whose chest was failing and had known exactly what to do and had done it with what she had available, which was not everything she needed, but was sufficient. The part that had memorized the hospital layout at 6 in the morning because she understood, from experience, that environments revealed themselves differently under pressure than under routine, and that the time to learn the difference was before the pressure arrived. The part that thought about the medical student named Priya, who had looked at her in the corridor that first morning with the particular expression of a young person registering the distance between what they'd been taught to expect and what they were actually seeing. She thought about what it would mean to build something that taught people to perform under conditions that the standard curriculum didn't address. Not heroics, not the dramatized version of emergency medicine that people imagine from the outside. The actual thing, the decision-making under degraded information, the clinical pattern recognition that came from enough exposure to enough patients, the specific discipline of staying functional when the situation was moving faster than comfort allowed. She thought about what that would have been worth to a younger version of herself. On the 6th day, she called Odell and said yes. The federal proceedings continued on their own timeline. She was deposed twice, once by the federal prosecution team, once by a Senate Oversight Committee staff attorney who was building the congressional record for what was already being described. In the news reporting, she occasionally and briefly checked as the most significant domestic espionage prosecution in several years. She gave both depositions the same way she gave clinical handoffs, sequential, accurate, without embellishment or performance. The protected witness, Raymond Dole, room 408, the man whose testimony had been the primary case, testified in a closed federal proceeding in December. She knew this because Calloway called to tell her it was done, which was a professional courtesy she hadn't expected and was grateful for. "How did it go?" Claire asked. "As well as it could." He held up. A pause. "He asked me to pass something along to you." "What?" He said, and I'm reading this from a note, he wrote it down. "Tell her the convoy personnel deserved better from the people responsible for their safety. The testimony is for them." Calloway paused. "That's the whole message." Claire sat with that. The convoy personnel deserved better from the people responsible for their safety. It was not a revelation. She had known this, had carried the wrongness of it for 5 years in the interior place where she put things she couldn't act on yet. But there was a difference between knowing something and having it spoken aloud by someone whose knowledge of it came from inside the network that had caused it, and the difference was not small. "Tell him I received it," she said. The man with the missing fingertip, the one she and Carver had taken down in the server room, was named for the purposes of the federal indictment as Dmitry Varel, and his role in the network traced back 11 years and connected to operations in 4 countries. He did not cooperate with the federal investigation. His trial was scheduled for the following year. She did not expect to hear much about it directly, and she was fine with that. Harlan Voss pleaded guilty in February. Not to everything. His attorney had done what attorneys do, and the final charge configuration was narrower than the initial indictment, though not by as much as the attorney had negotiated for. Conspiracy to obstruct justice and material support carried mandatory minimums that made the sentencing conversation shorter than Voss had apparently anticipated. His cooperation, such as it was, had yielded information of marginal value about network communications protocols that the federal team had already substantially reconstructed from the archive documentation. The sentencing hearing was open. Claire went. She did not go to watch him be punished. She went because she believed, with the specificity of a woman who had thought carefully about the difference, that there was a distinction between wanting someone to suffer and wanting the record to be accurate and the consequences to be real and proportional. She went because the hearing was the moment when the institution, not the hospital, but the larger institution of consequence, said formally and publicly what the facts were, and she wanted to be present for that. She sat in the third row. Voss was thinner than she remembered. The particular way authority had lived in his body, the set of his shoulders, the way he occupied space, was different now, diminished not by physical change, but by the absence of the thing that had made the posture possible. He looked, as Bev had said, like a man who finally understood what room he was in. Before sentencing, the judge permitted victim impact statements. There were 3. The first was from a family member of one of the soldiers killed in the Carmel Pass ambush, a sister who had driven from out of state and who spoke for 4 minutes in a voice that did not break, which was its own kind of statement. The second was from a federal agent who had been assigned to the protective detail for the primary witness and had been one of the 2 people killed in the 48 hours before the hospital events. The third was Claire. She had written it twice and thrown out the first draft because it had been too long and had explained too much, which was a habit she was trying to break. The reflex to justify, to contextualize, to make sure the listener understood all the steps that had led to the conclusion rather than just the conclusion. The second draft was shorter. She read it standing at the lectern with her hands flat on the wood on either side of the paper, because she did not want to hold the paper and she did not need to read it, but she wanted it there as a record. She said, "An institution is only as trustworthy as the people who choose its values over their own interests when those interests diverge." She said, the damage done to her professional record was correctable because the clinical facts were clear. But not everyone who is systematically discredited has clear clinical facts on their side. And the real cost of what Voss had done was not to her, but to the standard that said expertise and judgment should be assessed honestly, regardless of what the person carrying them looks like or where the scars are. She said she was not there to ask for anything in particular. She was there because the people who had been in that convoy deserved a witness who showed up, and showing up was the thing she knew how to do. She sat down. The sentence was handed down 40 minutes later. She noted it, registered that it was real and documented and would remain on the record for longer than the news cycle, and then she put it in the same interior place she put other things that were finished. She walked out of the courthouse into a February afternoon that was cold and bright. The sky above Delmont, that particular hard blue that came with winter at elevation. The mountains visible for once, sharp-edged against the clear air. Bev was waiting on the courthouse steps because Claire had told her she didn't need company for this, and Bev had heard that the same way she heard most things Claire said that were designed to manage what other people felt on her behalf. She had heard it and come anyway. "Done?" Bev said. "Done," Claire said. They walked to Bev's car. The director of emergency trauma training program launched in March with a curriculum that Claire had spent 8 weeks building from the ground up, beginning not with what existed in the literature. Though she had read it, all of it, the research and the gap analyses and the after-action reports from other facilities that had experienced mass casualty or active threat events, but with the actual list of things she had needed to know in her specific career that no formal program had given her. The list was long and specific and deeply unglamorous. It involved decision-making under degraded information. It involved communication strategies for clinical teams in conditions where the normal hierarchy was non-functional. It involved the physical and cognitive reality of working in a human body that was tired and stressed and still needed to perform accurately. The first cohort was 14 nurses and 3 physicians and 2 paramedics from the regional contracted services. She had expected resistance. She had prepared for it, prepared arguments, anticipated specific objections, had Odell available as institutional backing if the resistance came from a direction that required administrative support. What she got instead, in the first 2 hours of the first session, was attention. Genuine attention, the kind that came from people who had been in situations where they felt undertrained and had been waiting for someone to address it without dressing it up as something other than what it was. The physician who had been most visibly skeptical, a trauma surgeon named Dr. Emmett Rao, who had been practicing for 22 years and had initially, she'd heard through Odell, questioned the necessity of training led by a nurse, asked the most questions. They were good questions. Specific, technical, rooted in actual clinical experience. She answered them the same way she answered all questions, directly, with the information, without managing his ego or adjusting the answer to be easier to receive. At the end of the first session, he stayed behind. "I had a case last year," he said. "Mass casualty, vehicle accident on the interstate. We had more patients than we could manage in the standard triage configuration, and the communication broke down completely in the first 20 minutes. He paused. "I've been thinking about what I would do differently. This curriculum addresses 2 of the 3 things I've identified." "What's the third?" she said. He told her. She listened to the whole thing. Then she told him it was a gap she hadn't fully addressed in the curriculum and asked if he'd be willing to work through it with her, because his 22 years of trauma surgery contained knowledge she didn't have, and the program would be better for including it. He looked at her for a moment. "Yes," he said. "I would." She did not make a thing of it. She noted it, incorporated it, and moved on. Spring came to Delmont gradually, and then suddenly, the way spring came at altitude, weeks of false starts. And then one morning the air was different, and the mountains looked different, and the light had changed in a way that was not dramatic but was definitive. She drove to Nora's for the first Saturday that actually felt like a day for it, and her sister fed her more food than she needed, and her niece and nephew were loud in the way of children who had been cooped up all winter and were ready to exist at full volume again. Nora sat across from her after dinner with tea and the specific expression of a woman who had been waiting to ask something for a long time. "Are you okay?" Nora said. "Actually." Claire thought about actually. She thought about the personnel file that now had a formal correction in it, annotated in the language that official documents used to say, "The previous entries were wrong, and these ones are right." She thought about the program she was building and the 14 nurses in the first cohort and the gap Dr. Rao had identified. She thought about a mountain pass in 2019, and 3 men who had gone home, and a 4th who had not, and the difference between those 2 outcomes that had lived in the specifics of the decisions made in 11 minutes of chaos. She thought about this man in the trauma room who had kept his access code until he could give it to someone he trusted. The trust had not been misplaced. She thought about herself. Not the combat medic version, or the federal witness version, or the vindicated employee version, but the actual version, the one who had a shoulder that ached in cold weather and still dreamed occasionally about distances that expanded the faster she ran, and who had drunk bad hospital coffee with Bev Okafor in a nurse's station at 5 in the afternoon after one of the more consequential days of her adult life, and had felt, in that specific moment, something that was not happiness exactly, but was adjacent to it and was real. "Yes," she told Nora. "Actually." Her sister looked at her for a long moment, checking the answer against what she knew, which was considerable. "Good," Nora said, and poured more tea. On a Tuesday morning in April, a Tuesday, which was the day of the week she now had a mild and specific relationship with, she was at the nurse's station doing preliminary chart review before the first patients of the day when the medical student from the first morning walked in. Not a student anymore. Priya had matched into emergency medicine residency at a program in Denver and was doing a 2-week elective rotation back at Harlow County General, one of those circular returns that medical training produced. She stopped at the nurse's station and looked at Claire the way she had looked at her on that first morning, except the expression was different now. It had lost the apologetic register and gained something else, something more direct. "I've been thinking about that first morning since it happened," Priya said. "What he said to you, in front of everyone." "It was a long time ago," Claire said. "Not that long." Priya paused. "I should have said something. I didn't." "You were 2 weeks into your clinical rotation," Claire said. "There was nothing you could have done that would have been worth what it would have cost you." "That's not—" Priya stopped. "Maybe, but I've thought about it." "Then use it," Claire said. "The next time you're in a room and someone is being dismissed, use the fact that you've thought about it. That's what the thinking is for." Priya held that for a moment. "The trauma training program," she said. "The next cohort. Is it open to residents?" "3rd cohort," Claire said. "September. Put your name in with Dr. Odell's office." Priya nodded. She started to move toward the department and then stopped. "The day of the lockdown," she said. "I was in the break room when the code silver went off. One of the senior residents told us to stay put, but we could hear—" It was clear something was happening that the standard response wasn't going to handle. She paused. I didn't know what to do. I didn't know how to read it or what would help. I just felt useless. She looked at Claire directly. That's why I want the training. Claire looked back at her. Not at a student who had failed a test of courage. At a young physician who had identified exactly the right gap in her own preparation and was doing the correct thing about it, which was not to perform guilt, but to address the gap. September, Claire said. Put your name in. The April morning continued its ordinary business around them. The first patients arriving, the department coming up to speed, the accumulated daily work of a place that existed to receive people on their worst days and try to send them back improved. Claire returned to her chart review. The sun came through the narrow ED windows at an angle that the February sun hadn't managed. The mountains outside were visible, still snow-capped at the peaks, but with the snow line higher than it had been, receding with the season. There were things she still carried. She knew this about herself without drama. The shoulder that ached, the dream that came occasionally and then receded, the specific weight of certain information that did not resolve into nothing, simply because the institutional record had been corrected. These were not wounds she was waiting to be finished with. They were the cost of specific choices made in specific circumstances, and the cost was real and it was hers, and she had stopped expecting it to be otherwise. But she had also learned, was still learning, which was different from having learned, that carried weight and forward motion were not mutually exclusive, that the things you had been through did not determine the size of what you could still do, that the record of a person was not the opinion of the people who had looked at them and decided what they were worth. The record was what you actually did. In quiet moments, in the brief lulls between patients. When the department found its breath, she sometimes thought about the 11 minutes in the mountain pass and the 3 men who went home, and she thought about the trauma room and the man who held his access code until he found someone to trust, and she thought about a medical student who would be a resident in September and a surgeon with 22 years of experience who had a gap in his own knowledge and had said so directly. She thought about all the ways that human beings found to diminish each other, the performed cruelty of a corridor performance staged for an audience, the quiet machinery of bureaucratic suppression, the 6 hours it took a man to decide what he was willing to do for what the network was offering. And she thought about the countervailing fact that those things, despite being real and costly and leaving marks, had not been sufficient. They had not been sufficient. She had shown up. She had done the work. She had kept the record accurately in her own memory when the official record was wrong. And she had waited, without bitterness she could afford, and without certainty she never quite had, for the moment when the official record could be corrected. The moment had come. It had come because 2 witnesses had survived, because a server room access cascade had been terminated 2 keystrokes from completion, because a nurse in a trauma room had inventoried a crash cart by memory and repositioned a nasal cannula and made the clinical decision to tell a man the honest truth about his injuries instead of a more comfortable version of it. Small things. The kind of things that didn't announce themselves as the hinge points until afterward, when you could see the shape of the door they had held open. She finished her chart review. The first patient of the day came through the ambulance bay. Minor, manageable, somebody's difficult morning that would be resolved before noon. She went to meet them the way she went to meet all of them, present, accurate, ready to do the work that was in front of her. The scars on her neck caught the April light as she moved. She didn't cover them.